It's really my honor to introduce Connie Benson. Dr. Benson is a professor of medicine and global public health and the vice chair for education and ID training at the Division of Infectious Diseases and Global Health at UCSD. She has a number of roles there, including the director of the UCSD Antiviral Research Unit. She has a long history of work in the ACTG, in TB, HIV co-infection. She's a consummate educator and researcher, and really my pleasure to introduce her today to start the first talk on investigational antiretroviral therapies. Thank you, Connie.
Well, thank you for that kind introduction. And I'm going to share my screen. As you heard this morning, I'll be talking about investigational antiretroviral drugs and some purported strategies for their use. These are my financial relationships. These are the learning objectives for today's discussion. You can look at those in your syllabus at your leisure. And I'm just going to start off the topic by highlighting what we currently have available to us as first-line ART. And both the DHHS and the IAS-USA guidelines have recommended regimens for first-line ART. And as you can see, virtually all of the recommended regimens start with an integrase strand transfer inhibitor coupled with nucleoside analogs. There are minor adjustments for individual regimens depending on the underlying issues for individual patients, but very similar in each of these categories. The other point I'd like to highlight about this is that first-line agents in all of the categories, regardless of whether it's an INSTI, an NRTI, or boosted PI regimens, are now available in single tablet regimens for almost everyone. And each of these is extremely well tolerated. So you might ask, why do we actually need new antiretroviral drugs? And I think that will become obvious as I go through some of the studies for these new drugs in development. But there still remains a cadre of our patient population that experiences difficulty with some medications and certainly drug resistance. So the four classes of compounds that are in development that I'm going to talk about today include Islatravir, Lenacapavir, a GSK maturation inhibitor, and the promise of broadly neutralizing monoclonal antibodies. The first drug I'll touch on is a drug being developed by Merck. This is a nucleoside reverse transcriptase translocation inhibitor, and this cartoon just shows you where in the process of viral RNA replication this particular compound inhibits, and it results in chain termination. Islatravir is active at sub-nanomolar concentrations. It has approximately 10-fold greater potency compared with our current antiretroviral drugs. And a particular feature is its long plasma half-life and the even longer half-life of the active triphosphate intracellular component of the drug, which is the active compound. It's currently under evaluation for both prevention and treatment, and in a pill and injectable formulation. The major study that's been ongoing for the last year or year and a half has been the Islatravir P001 study. This is a phase 2b study design, and I'll walk you through this because it's a bit complicated. Treatment naive individuals who had detectable HIV RNA and a CD4 count of greater than 200 were randomized in part 1 of the study to one of 3 different doses of Islatravir and a control arm of doravirine 3TC and tenofovir. The companion drugs for Islatravir also included doravirine and 3TC. Patients were continued on these regimens for the first 24 weeks of part 1, and those individuals who had suppressed RNA at week 20 then went on to part 2 of the study, which reduced the 3 Islatravir arms to a 2-drug regimen of Islatravir plus doravirine alone, removing the 3TC component, and then the 4th arm continuing with the background compound of doravirine, 3TC, and tenofovir. And then part 3 if individuals continued to tolerate or were suppressed at week 60 through 84, were rolled over to a maintenance arm of Islatravir 0.75 milligrams plus doravirine or their underlying control arm and continued in follow-up through week 44. The key findings related to safety were that there were no discontinuations for safety events after week 48, and only one serious adverse drug reaction occurred in part 3. The efficacy data for the 96-week time point was reported at the Glasgow meeting in 2020. And I'll just highlight that here, showing you that for the 0.25 and 0.75 milligram Islatravir dose, there was an 86 to 90% proportion of individuals who were suppressed to less than 50 copies. The combined arms, similar suppression rates and similar to the control arm in all situations. The only exception was the high dose Islatravir arm did not appear to perform as well. The week 144 efficacy data were presented at the EACS, the European AIDS Conference, just this past few weeks, and also demonstrate similar findings out to week 144 with a 75 to 80% viral suppression rate to less than 50 copies for the majority of people in the study, and only 7 patients experienced protocol-defined virologic failure by that time point. However, although they were discontinued from the trial, their confirmatory HIV RNA levels were still less than 80 copies. So they were above 50, but less than 80. There were no instances of clinically significant confirmed viremia, and therefore resistance testing could not be done in these 7 virologic failures. The safety data at week 144 are highlighted on this slide. And the most common drug-related adverse events were nausea, diarrhea, headache, and abnormal dreams, that presumably due to the doravirine component. There was a lower rate actually of drug-related adverse events in the 2-drug combination of Islatravir and doravirine arms than in the 3-drug combination control arm. All discontinuations due to an adverse event occurred before the week 48 time point, and there were no deaths or serious drug-related AEs. Islatravir is also being developed for PrEP, or pre-exposure prophylaxis, and data from the IAS this summer reported the week 24 data from a phase 2A randomized double-blind multicenter placebo-controlled trial with this compound. This study population included individuals who were not HIV infected, otherwise healthy between the ages of 18 and 65, and at low risk for HIV acquisition. Patients were randomized in the blinded portion of the study to one of 2 different doses of Islatravir, in this case given orally every 6 months, and compared with a placebo. The primary endpoints in this study were safety and tolerability and pharmacokinetics, both overall pharmacokinetics of the triphosphate form and pharmacokinetics in peripheral blood mononuclear cells and in tissue. And if you look at the PK data in all portions of the study at 4 weeks after the first dose, 4 weeks after the last dose, and 8 weeks after the last dose, Islatravir concentrations at both treatment arms were above the PK threshold for activity and above the target thresholds. The drug was very well tolerated in this study, and a phase 3 PrEP trial is beginning at 600 milligrams dose of Islatravir given monthly. So Islatravir is continuing in ongoing clinical trials, phase 3 studies in treatment naive, phase 3 studies in heavily treatment experienced individuals, in people with HIV who are virally suppressed, who are willing to switch from other regimens, and in phase 2 studies in children and adolescents. And these are just the clinicaltrials.gov designators if you want to look up the designs of these studies. The next compound I'm going to highlight here is Lenacapavir, or GS6207, being developed by Gilead. This is a novel first-in-class capsid inhibitor. We've talked about this compound at IAS-USA symposiums over the last year. But just to highlight a few additional points, it's active against a broad range of HIV-1 isolates, including those resistant to currently available classes of ARVs. Its action is felt to be occurring through modulation of stability and/or transport of the capsid complexes, and thus inhibition of multiple processes necessary for viral replication. It's active at picomolar levels or concentrations and is more potent than current antiretroviral drugs. And it too is being developed in both an oral and a parenteral or sub-Q formulation. Just some resistance highlights presented at CROI this year suggest that the activity of this drug is robust against all HIV-1 subtypes. In vitro resistance appears to arise at 6 amino acids at the Lenacapavir capsid binding site, and I've listed these here. Most resistance mutations, with the exception of the Q67H mutation, correlate with low replication capacity, so it inhibits the replicative ability of the organism, even in the presence of resistance mutations. Pre-existing Lenacapavir mutations have not been found in testing of more than 1,500 HIV-1 clinical isolates, so that's good news. But when Lenacapavir resistance does occur, the HIV-1 isolates appear to retain susceptibility to HIV protease inhibitors, and so this class of drugs may be useful to rescue a Lenacapavir resistant isolate. Lenacapavir is also 20 times more active against HIV-2 than HIV-1, although this is not particularly pertinent for treating our patients here in the US. There were data presented at CROI 2020 looking at the 10-day antiviral activity in people living with HIV and in an oral dosing study in healthy volunteers. Both of these were dose ranging. The one in people living with HIV was given subcutaneously, and the one in healthy volunteers orally. And as you can see, there's a dose-response relationship in both of these studies with an HIV RNA decline ranging from 1.4 to 2.3 log with the subcutaneous dose. And the most common adverse event was an injection site reaction. There were some laboratory abnormalities that included asymptomatic elevations of CPK and amylase. And the single dose oral dosing up to 1,800 milligrams was also safe and well tolerated and showed a similar dose response relationship with viral suppression. This led to the onset of a phase 2A study with Lenacapavir called the CAPELLA study. And this one is in heavily ART experienced people. Eligibility for entry was an HIV RNA level that was detectable at greater than 400 copies and resistance to at least 2 agents from 3 of the 4 main ARV classes and less than at least 2 fully active agents from these 4 main ARV classes. So there was a second screening HIV RNA done, and then patients were randomized based on that second screening assay if they had lower viral loads that were less than 0.5 log, a decline of less than 0.5 log from their original screening assay, so still detectable at greater than 400 copies, the patients were then randomized to what was effectively functional monotherapy with oral Lenacapavir plus their failing background regimen, or placebo plus their failing background regimen. Those individuals who had lower viral loads or less than 400 copies at the time of their second screening level did not undergo randomization, but went directly to oral Lenacapavir with optimization of their background therapy. These 3 groups were then followed for 14 days and then rolled over to maintenance therapy with subcutaneous Lenacapavir given every 6 months for a year, plus optimization of background therapy, or oral Lenacapavir for an additional 14-day lead-in in the placebo group, and then subcutaneous Lenacapavir every 6 months, and then continued follow-up for this non-randomized arm. The primary endpoint achieved in the analysis, which was at least a 5 log decline by 14 days, occurred in 90% of those receiving Lenacapavir versus 17% in those in placebo, and it resulted in almost a 2-log reduction in viremia in the first 14 days. These patients were then continued on for a week 16 randomized cohort follow-up. The baseline characteristics are displayed here, and the only point I want to make about these, they were relatively well balanced across the 3 arms of the study, but you can see that these patients had high-level drug resistance, had been HIV infected for a long period of time, and had experienced treatment with greater than 9 prior antiretroviral drugs, so heavily treatment experienced. So looking at the efficacy at week 26 in this randomized cohort, you can see that 89% and 81% respectively had HIV RNA suppressed to less than 200 and less than 50 copies by week 26. And this did depend on what fully active agents were available in optimized background therapy. In the non-randomized component that had greater than 2 drugs in optimized background, you can see 81% were suppressed. In the randomized cohort, if there was at least 1 drug in optimized background that was fully active, 86% were fully suppressed, and then less suppression in those who did not have any active drugs to optimize their background therapy. Overall, there was a rise in CD4 cell count of greater than 81 cells for most individuals, and no further decrease in low levels of CD4 counts. When looking at the resistance data from this study, all 4 patients that had treatment emergent lenacapavir resistance remained on lenacapavir. 3 of these patients resuppressed their HIV RNA at a later visit, and only 1 had a change in optimized background therapy. And these are the emergent resistance mutations that were observed. 1 patient that had no fully active companion drugs never fully suppressed their HIV RNA, but did have a 1.7 log decline. No patients developed additional resistance to optimized background drugs. So this compound is continuing in clinical trials. The safety data were similar to the early phase 1 data, with the primary adverse events being diarrhea, nausea, headache, and a host of minor constitutional complaints. And again, 1 patient or a few patients with elevated asymptomatic creatinine levels and fasting hyperglycemia. Overall, the most significant adverse events were the injection site reactions. You can see them described here with their cumulative incidence of 56%, having at least 1 injection site reaction, but most of these were grade 1, only 2 were grade 3, there were no grade 4, and all 36 patients in the randomized component of the cohort went on to their second lenacapavir injection. So the conclusion for heavily drug-resistant patients was that lenacapavir combined with optimized background therapy was effective and safe out to week 26 with a 81% rate of viral suppression to undetectable levels and an 81 cell increase in CD4 cell count with a well-tolerated adverse event profile, none of which led to discontinuation of drug. And this is now in ongoing clinical trials. So lenacapavir is also being tested in people with HIV who are treatment naive and have detectable HIV RNA and a CD4 count of greater than 200. This too, you have to give it to Gilead for creating some of the most complex study designs here. But in an open label phase 2A study design, dividing these patients into 4 different groups, there was an induction phase for group 1 and group 2 of lenacapavir given subcutaneously Q6 months in combination with FTC and TAF. And then at the end of that week 28 endpoint, if those individuals had less than 50 copies at both week 16 and 22, they were then switched to a 2-drug maintenance regimen, with half of these switched to a TAF plus lenacapavir maintenance regimen and the others to bictegravir plus lenacapavir maintenance regimen, and then continued on treatment. There was also a group 3 that was originally randomized to oral lenacapavir plus FTC and TAF, and group 4 to a control arm of bictegravir, FTC, and TAF. These are the distributions of participants at baseline, and the primary outcome was proportion less than 50 copies at week 54. And I'll just highlight the week 28 virologic outcomes for you here, recently presented at the IAS conference this summer. And you can see that using the FDA snapshot intent to treat, all 4 arms had high proportion of individuals who were fully suppressed to less than 50 copies. There was 1 participant in the lenacapavir sub-Q switched to 2-drug bictegravir arm with lenacapavir that had emergent resistance mutations at week 10. These were those mutations. They resulted in a 20-fold change in lenacapavir activity, and plasma concentrations for lenacapavir were consistently maintained in the target range. Adverse events seen in this study, including injection site reactions, are displayed here. Lenacapavir was well tolerated. There were no serious or grade 4 adverse events. The most common adverse events were headache and nausea in about 11%. And interestingly, the subcutaneous arms had higher rates of GI adverse events than the oral lenacapavir arm. Injection site reactions, as I pointed out earlier, occurred in about 39%. 83% of these were grade 1 and generally resolved rapidly. This drug is continuing in clinical trials for both treatment experienced and treatment naive individuals, and lenacapavir is now also being tested in a randomized clinical trial for pre-exposure prophylaxis. The next compound I want to discuss is the next generation maturation inhibitor being developed by GlaxoSmithKline. It's got a long number here, and I'm just going to refer to it as GSK254. This drug prevents the proteolytic cleavage of specific portions of the GAG protein, which prevents processing at the GAG-POL polyprotein level in late stages of HIV replication. You've heard us talk previously about the earlier maturation inhibitor, Beviramat, but pre-existing mutations at that cleavage site led to termination of development of that compound and the emergence of this next generation compound. And GSK254 is now being tested in a phase 2A randomized clinical trial that I'll go through with you here. This too, relatively complicated study design. Treatment naive people with HIV were randomized to part 1 of the trial in 2 different doses of 254, a high dose and a low dose, and then compared with placebo. This was an effective monotherapy component. At day 10, they were switched to a combination antiretroviral therapy, and then at a planned interim analysis, the data for these part 1 patients was analyzed. At that point, it was detected that resistance mutations occurred in the groups receiving 254 in the 10-day monotherapy component, and therefore the follow-on part 2 of the study reduced that 10-day monotherapy period to a 7-day monotherapy period and randomized an additional group of treatment naive individuals to receive 3 different doses of GSK254, 140, 80, and 40 milligrams respectively, compared with placebo. And then at day 8, were switched to combination therapy. And these are the baseline characteristics of the patients who were in these studies at all of the dose levels, relatively similar across all of the treatment arms, mostly male and mostly white, as often is the case with these new drugs, and mostly similar levels of baseline viral RNA. Looking at the antiviral activity in part 1, you can see that the 10 milligram dose and the placebo arm had roughly similar levels of suppression, hence no longer looking at the 10 milligram dose, but the 200 milligram dose had a nearly 2 log viral load suppression at day 10. And in part 2, with the reduction to only 7 days in the monotherapy component of part 2, all 3 of the GSK 254 doses in a dose response pattern reduced viral loads to 1.5 to 2 logs, while compared with placebo, no change. When looking at the resistance profile for this maturation inhibitor, the resistance mutations detected in that first portion with the 10-day monotherapy component occurred in 4 of the 6 patients at the 200 milligram once daily level. And this resulted in full conversion and phenotypic resistance in only 1 of these 4 patients, however. There was no resistance detected in the 10 milligram per day group, but as you know, that had no antiviral activity, and that's why no resistance was seen. A protocol amendment that reduced it to a 7-day monotherapy in part 2 then demonstrated substantial viral load reductions in that 7-day monotherapy period. And then after initiation or after discontinuation of the drug, loss of sensitivity occurred in those individuals who had that resistance mutation. So in conclusion, in ART naive persons with HIV, this novel HIV-1 next generation maturation inhibitor demonstrated a clear dose response activity. Viral loads were decreased to 1.5 to 2 logs in doses ranging from 140 to 200 milligrams daily dose. It was well tolerated with no adverse events that required drug discontinuation. And there were no further mutations occurring in individuals who were in part 2 of the study, suggesting that this compound will go on to further development in combination with other antiretrovirals. The last group of compounds I'm going to highlight today, you've heard a lot about these in many numerous IAS-USA symposia and meetings previous to this, are the broadly neutralizing antibodies. These are in development both for PrEP and for treatment and for vaccine prevention. So broadly neutralizing antibodies, an extremely important class of compounds aimed or targeting HIV-1. There are many different kinds of broadly neutralizing antibody, and this slide, courtesy of Pablo Tebas, illustrates where these act against the virus. CD4 binding site at V1, V2 binding site, V3 or the glycan patch site, or the GP120, GP41 interface, or at other sites. So multiple different types of broadly neutralizing antibodies in development. Each of these have varying levels of antiviral activity against HIV and are in varying stages of development. I'm going to highlight just a couple of these approaches that are in clinical trials currently. These 3 are studies that are being done by the AIDS Clinical Trials Group Network. The first of these is a single-arm trial proof of concept looking at the combination of the VRC07 broadly neutralizing antibody and combining it with long-acting cabotegravir as maintenance antiretroviral therapy. The second trial is a single-arm trial combining 2 broadly neutralizing antibodies in an effort to prevent relapse of viremia after discontinuation of oral antiretroviral therapy, so more of a cure approach. And the last trial is the first in human phase 1 clinical trial of a tri-specific monoclonal antibody acting at 3 different targeted sites. And this is to establish safety, PK, and preliminary antiviral activity. We hope to have results from each of these trials in the next year, looking at the activity of this approach. There's also an ongoing phase 1 study with Gilead monoclonal broadly neutralizing antibody in people who are virologically suppressed. So I'll just summarize here by indicating that the pipeline is robust for development of investigational ARBs that have unique mechanisms of action, improved activity compared with many of the first-line drugs and regimens. Each of these is currently also being developed as a long-acting injectable formulation and is continuing to demonstrate the promise of these long-acting injectable drug formulations and their potential for changing the landscape of treatment with antiretroviral drugs, potentially giving us fewer drugs, fewer pills, less drug resistance, and possibly lower cost. although that remains to be established. There are a number of trials ongoing with alternative strategies using these compounds as well as cabotegravir as another long-acting injectable drug now approved for use in combinations with these agents and in combinations in populations that may struggle with adherence. And we hope that these trials will provide insights into novel future use of these long-acting injectable drugs. And I'll stop here and thank you for your attention. So we have the option for any questions and answers to be placed in the Q&A box, and I will, okay, now we have our host on. I was just gonna take over here and go with the Q&A, but I'll turn it over to you, Monica.
Thank you. Thank you so much for your great talk. So we do have some really good questions coming in to the Q&A. And one question for you, Connie, is what was the reasoning for using Islatravir with doravirine as opposed to other ARVs? Usually
well, you're asking me now to get into climb into the heads of the pharmaceutical companies that put these things together. And I don't have a good answer for that. I think doravirine is a very active NNRTI. I think they were trying to avoid looking at integrase inhibitor class drugs as a direct comparison or incorporated with Islatravir, as there was already with the Islatravir studies an integrase inhibitor comparative arm. So they wanted to look at something that was a companion drug that was not an integrase inhibitor. And then, of course, when you get into PIs with boosting, there are drug-drug interactions and issues like that that you want to try and avoid. So I think also doravirine, they were kind of mirroring the experience with the longer acting NNRTIs like rilpivirine has done with cabotegravir. So these are only my suppositions. I'm not privy to the rationale that was developed by the companies. If there are other people
really
who know
could be as simple as Merck makes both of them.
Well, I was going to say that, but I didn't want to sound too partisan there, but that may be the only explanation.
But I think you're right. There's good reasons to combine them. Other questions that have come in is, do you think that maturation inhibitors, this is a really interesting question, would work only in those with detectable viral loads? Because you get to that point of the viruses are off.
You know, that's a very good question. It's only been tested in people with detectable viral loads. And as far as I'm aware, there's not an intention to do a switch trial like we've done with many of these other new compounds in people who are fully suppressed. But we also know that people who are fully suppressed may also still have low-level viremia that we're just not detecting. So I would expect that you would continue to see an activity even in virally suppressed patients. They certainly, once they're virally suppressed in the monotherapy arms of the phase 1 trials, when put on combination therapy, there was still some activity. So I would expect us to still have activity.
Okay, thank you. And then one question is from Dr. Nash is, do you have any comments on the phase 1-2 trials with the CRISPR-Cas9 treatment for potential cure? I know that you're talking about investigational treatments, but any comments?
I think they're very attractive approaches. And obviously the CRISPR-Cas9 approach physiologically and pathogenetically is a very attractive one to be able to alter what's happening with the virus directly. Aside from having promise in clinical trials, I don't have any experience in the conduct of clinical trials with those agents as of yet. They're in very limited stages of development. So hopefully we'll be able to talk about those compounds and the effects as we get to next year's conferences.
Great. And then another really good question. You talked about a number of different investigational agents. Can you comment in general on the barrier to resistance of these new compounds? You know, if we think about bictegravir, dolutegravir, and boosted PIs as having the highest genetic barrier to resistance. Any comments on Islatravir and the others that you?
Yeah, we don't have a lot of resistance data on Islatravir yet. There was, as you saw from the data that I presented from the studies that are being done with that drug, we didn't see emergence of resistance with Islatravir in those early stage studies. With Lenacapavir, it does appear to have a lower barrier to resistance, as you saw. Some of those patients who were switched over to a 2-drug regimen had emergence of resistance mutations that conferred decreased activity against the drug. And we also saw, excuse me, pretty rapid emergence of resistance with the maturation inhibitors. So I think the question is appropriate. They appear to have a lower barrier to resistance, at least as we've seen from the data thus far. I think we'll have to look at that question as we see phase 3 trial results emerge, because that's going to be a big question about how useful these agents are going to be in the future.
And then another question that's come up is, and I think this is 2 drug companies were talking, but has a clinical trial of Islatravir and Lenacapavir been?
As far as I'm aware, no. I don't know if anyone else knows about that, but
I think they did just announce. I know. I think they did talk. So this would be, you know, Merck making Islatravir and Gilead making Lenacapavir, and it just literally announced a couple of days ago that they're going to combine them and try a trial of once weekly therapy with these 2 agents. So let's see what once weekly therapy does for our patients. Okay, this is an interesting question, which is, do you think that the M184V would decrease the efficacy of Islatravir? Dr. Folco says that there's some data that she's seen. I haven't seen that, but I don't know if you've seen about M184V affecting the NRTTI.
I have not seen data to suggest that there's a decrease in efficacy of Islatravir, but then again, as you see from the phase 1 and phase 2 trials that I showed you, most of the patients in those trials were suppressed sufficiently that emergence of resistance mutations were seen with the background NRTIs. So I think that's a question, again, that remains to be seen when we see data from the phase 3 clinical trials.
Okay, great. And we do have some time for a few more. So yeah, Dr. Folco said it was reported in an article. Yeah, I haven't seen that. So that's really interesting about that. So yeah, we'll have to look. That is actually all the questions that I see in the Q&A, unless anyone has any further comments or questions that they want to make. Okay, great. Thank you so much for your presentation. That was amazing. And I think it's an incredibly exciting time in HIV medicine to be at the verge of all of these new medications. So thank you again.
And thank you to our audience for raising a couple of good points to educate us as well. So thank you.
Thank you.